I will talk today about left heart catheterization. During typical left heart studies, I routinely access the LV mainly to get LVEDP, but sometimes also to assess severity of aortic stenosis and aortic gradient in questionable cases, and sometimes to do left ventriculogram, especially in cases of questionable severity mitral regurgitation. So I will describe the steps and I will provide cases to illustrate that. First, in standard cases, I typically cross into the left ventricle with a standard Judkins right catheter, the same Judkins right I'm using to engage the right coronary artery before or after right coronary engagement. You may also use Tiger catheter or whatever you're using to engage the right coronary artery. I typically cross into the left ventricle using a wire, and I track the catheter over it. And I use the catheter to direct the wire, and I cross with the wire. How do I do it? I typically use the following steps. One, I use an LAO view to separate the right versus left cusp, right or non-coronary cusp versus left cusp, as I explained in the past. And I aim to the hole in between, the lower cusps, right or non-coronary, and the left cusp. Two, I advance my catheter and wire all the way till they touch the aortic valve, and they typically touch the lowermost cusp. They fall into those lowermost cusp. Very importantly, as in all our heart catheterization maneuvers, you need to know which cusp you're in. If you are touching the valve and the catheter falls down, you are usually in that right or non-coronary cusp, as is often the case. If you push the catheter while you're on the valve, it will fall onto that lowermost cusp. If the catheter jumps up while you're on the valve, you're usually in the left cusp, okay? So once you're in that cusp, typically the right cusp, what you do, you pull the system up, the catheter and the wire, and as you're pulling up, as you're jumping out, you advance the wire and you aim to go in between. So as it is jumping, you advance the wire and you get into the ventricle, then you track the catheter over it. So you cross with a wire directed by a catheter. If this doesn't work, if as you're jumping, you advance the wire, it doesn't go, it ends up looping over a cusp, then you reattempt. You pull back your wire, you give a torque of that catheter, you pull and push the catheter, you give a different direction, and you re-advance the wire. It doesn't work, you pull back the wire and you reattempt. The biggest mistake I see is that people keep looping in the same cusp. They never get out of the cusp. They keep torquing that catheter and pulling and advancing the wire into that right cusp. They are stuck into it. They need to pull a little more, see it jump and advance the wire in between. They need to jump out of that right cusp. This is an illustration here of a case done by a fellow. So you see here, he's in the right cusp and he's advancing the wire. It's being looped in the right cusp. So each time he pulls out, reattempts, give the catheter a different torque, different maneuvering, and reattempt to advance the wire. Then eventually you can see he jumped out. He saw he kept looping into that right cusp. So he pulled, and watch here the jump. Here, this is a jump. You saw how he jumped? Then he advanced the wire and it went in. When you see the jump, you know you're very close to crossing. Another thing you may see, and I'll show other cases, if you see that wire starting to dance between looping on the right cusp, then looping on the left cusp, you know you're very close to crossing. That dance of the wire right to left tells you you're very close to crossing. Another important technique is, as I explained in the past, when we're engaging the coronary arteries, your hands, both of them are on the catheter, and you torque with both hands in sync, torque and pull or push with both hands in sync. When you're trying to cross the ventricle using a wire, both your hands are on the back. One hand is on the catheter back, another hand is on the wire. That hand, directs the catheter, it torques and pulls the catheter, while this hand advances the wire off and on. Only when you need to push the catheter, when you've pulled too much and you need to get back onto that valve and give support to that wire, then you move your hand forward. So it's typically both your hands are in the back. Whenever you need to use and maneuver the wire in and out, your hand needs to be in the back, such as, for example, when you're crossing from the descending to the ascending aorta, you're doing counterclock, and you're ready to advance the wire once your catheter jumps into the ascending aorta. So whenever you're actively using the wire in and out, this is how your hand position should be. This is how your hand position is when you're engaging the coronaries. This slide summarize those ideas. Again, recognize which cusp you're in, low position, it's right cusp or non-coronary cusp, pull out and up. Do not get stuck into one cusp. And if the GR4 doesn't work in patient with a large aorta, think of other catheters to point you further up and get you out of that right coronary cusp and point you out of it, as I will explain in a little bit. This is an illustration of another case. We already jumped out of the right cusp. So we were in the right cusp, we pulled up, and here is advancing the wire. And you can see initially the wire is in the right cusp, then it's in the left cusp. And whenever you see that, as I explained, that dance right, left, you're very close to getting in. And this is an illustration with drawing the cusp so you can see. Again, it dances right cusp, left cusp, then it goes in. Now, I explained how to get into the left ventricle when you want to measure LVEDP using a standard catheter, like a Judkins Wright. Now, if you want to do left ventriculogram, and sometimes if you just want to get LVEDP, you may use that catheter called pigtail catheter. It's a very nice catheter for left ventriculogram, as the round tip on that catheter prevents it from being stuck against the wall. In addition, it also has 6 to 8 side holes throughout that tip that allows you to inject dye in a concentric fashion into that ventricle, rather than have a high pressure jet filling of the ventricle into one point, like you would do if you inject via a Judkins Wright catheter. If you want to do left ventriculogram, you need to use that catheter. Don't use an end hole catheter like a Judkins Wright or a Tiger catheter. I think when you use those end hole catheter, you risk staining and perforating the myocardium because you're having a high jet into one direction, into one point of the ventricle. There is angled pigtail catheter and there is a straight pigtail catheter. I use the angled pigtail catheter, which embraces better the geometry of the left ventricle. It also embraces more nicely the geometry of the ascending aorta into the left ventricle. Now, how to maneuver with a pigtail. So I explained how to cross with a Judkins Wright. I usually use a wire to cross into the ventricle when I'm using Judkins Wright. However, when you're using a pigtail to cross into the ventricle, you can cross with a pigtail directly without the wire. So there is a special maneuver. You get your pigtail catheter at the lowermost cusp, right, or non-coronary cusp. Then you make the pigtail itself jump up in between the cusp. And as you're jumping up, you push the pigtail. You make it loop to become like a figure of 9. And as it's looping and as you're pushing it while you're jumping out of the right cusp, frequently it falls in. This is how we do it. So we push as we're jumping, we loop it, figure of 9, and we frequently fall in. If we don't fall in, we repeat this maneuver. We pull back the catheter, and as you're pulling back, give it a slight torque, whether clock or counterclock. If you're in the proper position between the cusp, as you're pulling with a clock or counterclock, you frequently fall in. If you don't fall in, again, you pull with a slight clock or counterclock, then you re-advance again and try over. And each time you give it a different torque and try again. Again, one big mistake when you're doing this maneuver is that you're stuck into one cusp. So you keep looping that catheter onto the right cusp, off and on. Realize, don't keep being stuck into one cusp. Try to free yourself. You need to, if you're having a hard time getting to the ventricle, that means you're stuck into that right or non-coronary cusp. So try to jump out and loop it in between. So as I said, I don't use the wire to cross into the ventricle with this maneuver. However, with the pigtail, however, I keep the wire inside the catheter to give it stiffness and robustness, particularly as I'm looping over the cusps. So I avoid kinking that catheter, especially if you're using 4 French or 5 French. You can kink the catheter. So I keep the wire in to prevent the kink and to provide more robustness to the catheter. Now, sometimes you will feel the catheter form that fall. You see that arm of the catheter fall into the ventricle, but the catheter hasn't fully fallen. It's very easy. That's another advantage of having the wire ready. Once the arm falls, just advance the wire and the whole system will fall into the left ventricle. Always, it always does that. When the arm falls, advance the wire, the whole system will fall in. So I describe how to cross with the pigtail catheter itself without using the wire to cross the valve. However, you can use a wire to cross with a pigtail. You can use a wire as I described with the Judkins Wright, except it's a little harder. You can use the wire directed by the pigtail to cross into the left ventricle. So here is how to do it. And I do that when I try multiple times to cross with the pigtail itself, looping the pigtail itself to fall, and it doesn't fall. So I eventually use the wire itself outside of the catheter to try to cross into the ventricle. And here is how I do it. So I advance the wire. Remember the pigtail, if you just advance the wire through it, it will point the wire upward because of the shape of the pigtail. It's not like a Judkins Wright, which can point you toward the valve. It will point you upward into the ascending aorta. So you advance the wire through the pigtail. Then as you're advancing the wire out, you pull on the pigtail catheter so that the pigtail tip is on the stiff portion of the wire and it's straightened. So the pigtail becomes straightened and becomes like a Judkins Wright. So that's how you do it. You advance the wire while you're pulling on the pigtail catheter to make it to make the tip more angled. And in this direction, in this orientation, you use the catheter to direct the wire like we do with the Judkins Wright 4, as illustrated in this figure. You start torquing the catheter and directing the wire aiming to the hole between the cusps. I find it harder to do this with a wire with a pigtail catheter compared with a Judkins Wright catheter, simply because that pigtail, as you're maneuvering the wire, pulling it in and out, it will tend to go back and embrace its pig shape and sometimes make that wire point in the aorta like this. So it's feasible, it's a little harder, it requires a little more finesse to cross into the ventricle with a wire. So I explain how to cross the ventricle in all standard cases. I will move to describe how to cross the ventricle in cases of severe aortic stenosis. It's basically the same technique I described here about how to use a standard catheter and wire with extra tips. And here are the extra tips. So when you want to cross any severe AS, it's often important to do a small aortic root angiogram, usually in an LAO view, to delineate the aortic valve hole and cusps. So you have a narrower hole in case of aortic stenosis, and you want to aim toward that hole. And doing an aortic root angiogram helps delineate the cusp and the exact hole, so you know two things: which catheter will point me toward that hole, and two, how to direct my catheter to point toward that hole. I use that image as a reference, and I aim toward that hole. Aortic valve calcium, all patients with severe AS should have aortic valve calcium visible on fluoroscopy. If they don't, you question whether they truly have severe AS. So you can use that aortic valve calcium. However, the aortic valve calcium will not show you exactly where the hole is. So I frequently like to do that aortic root angiogram. And just to give you the general setup, a reminder of what we eventually want to get in AS, we want to get a catheter inside the ventricle. And typically we have this setup. We have a long sheath, for example, from a radial axis, a long 6 French slender sheath that's sitting in the ascending aorta. And inside it, we have in the ventricle a 4 French catheter, such as a 4 French pigtail catheter in the left ventricle. We measure LV pressure from this, and we measure aortic pressure from that. The gap between 6 French and the 4 French allows us to still be able to measure the aortic pressure from the sheath. Another setup, the second most common setup in AS assessment, is you have your standard sheath in the radial or femoral artery, and through it you eventually position a 6 or 7 French Langston catheter, which is a double lumen catheter. It's a catheter that has one lumen that ends in the ascending aorta and one lumen that ends at the very distal tip in the ventricle. It's a pigtail catheter that has 2 lumens. And you can measure LV and aortic pressures through that one catheter. But how do we get there? We need to cross that aortic valve and eventually put that catheter or that catheter inside the left ventricle. Now, the way to cross it, like I said, one first tip is to do an aortic root angiogram to delineate the anatomy and pick the proper catheter. And there are different aortic configuration, and you need to have this in your mind and need to imagine what catheter works for every configuration. For a standard configuration, Judkins right catheter may work for this configuration. For the more common configuration in an elderly severe aortic stenosis, Judkins right will not be able to cross the aortic valve. It will get stuck into the right or non-coronary cusp. You know, it will be stuck here. You'll keep trying to advance your wire and it will keep looping over the right cusp. You need to get a bigger and wider curved catheter to aim toward that hole. And that's the beauty of that aortic root angiogram. It shows you what do I need to do. It makes you understand that aortic configuration. Frequently, the most commonly used catheter to cross AS is usually an Amplatz left 1. Sometimes Amplatz left 2 is the aorta is significantly dilated. So we use that catheter to aim to the valve. Typically, unlike standard cases, I use a straight tip wire, not a J wire, to cross severe AS. You can try with a J, it may cross, but typically I use a straight tip wire to cross the narrow hole of aortic stenosis. Such an example would be ADX wire by Angiodynamics. It has a straight, soft tip, but it's a little stiffer of a tip than a woolly wire, which is also straight tip. So, but I prefer that one. You can also use straight glide wire, stiff body, soft tip, straight glide wire, which I've used in the past as well. So the most important thing, though, is to have a catheter that points to that hole, is to understand where the hole is and point to it. People think that it's harder to cross aortic stenosis because the hole is narrower. And they think the tighter the hole, the harder it is to cross. That is not true. We've had critical AS cases that we crossed in seconds, and we've had no AS standard cases that took minutes to cross. The main difference is you understand your anatomy and you're aiming toward that hole. That's the main difference. AS does not make it dramatically more difficult to cross into the ventricle if you have the proper gear and you understand your anatomy. So I use the catheter to direct that straight tip wire, and I get in the ventricle. And once I get my catheter in the ventricle, I track that Amplatz left over it. And then I have to exchange to those catheters, whether the Langston catheter or the pigtail catheter, to measure my LV pressure. The Amplatz left is not a good catheter. It's very arrhythmogenic. It tends to poke at the ventricle, and you're not going to get good tracings with it. Plus the fact I often cross with a 5 or 6 French Amplatz left. So we need to switch for something smaller if we're doing, for example, sheath and LV catheter measurement. We need to put something like 4 French, maximum 5 French, to do that configuration measurement. So I cross, I put the Amplatz left into the ventricle, then I exchange for that, for example, 4 French pigtail catheter, or for the 6 French Langston, using an exchange length standard J-tip wire looped in the ventricle, or you can use an Amplatz extra stiff wire in difficult configuration cases with a loop on the tip of it. Okay, now if it is taking a long time to cross, remember, when you're maneuvering catheter and wire to cross in the ventricle, you need to flush the catheter every 2-3 minutes, take the wire out and wipe it, and reattempt. Do that every 2-3 minutes and give heparin, usually about 5,000 units or 50 units per kilogram. This is an example of aortic stenosis. This is an Amplatz left catheter. So here we took an aortic root or aortic cusp angiogram, and we see the hole here. We see the right cusp and we see the left cusp, and we know where the hole is and how to aim. And I use this as a reference here. I put it next to me as a reference, and we start maneuvering with the catheter and the wire to cross in the ventricle. And you see how we're doing it here. So we're aiming, you see the wire first, it's looping on the right cusp. So we pulled, then it's touching the left cusp, then you know it's going to cross soon. Watch again. So it's looping, straight tip wire looping on the right cusp. So we changed the catheter, we torqued it, and now it's touching the left cusp, then we cross. So again, same idea. You touch the right cusp, you do maneuvering, you end up on the left cusp. You know you're dancing right to left cusp with your wire, you're very close to crossing, and that's what happened. You just very tiny maneuvering and you'll get right into the ventricle. This is another case. This only took a few seconds to cross, actually. Again, with an Amplatz left, we understood the configuration here. I did not need to use cusp angiography. And we advanced the wire. You can see it was dancing, right cusp, then left cusp, then in. See again. Right cusp, then left cusp, then in. One way you can understand that configuration without injecting dye, I suggest you inject dye. It helps you see not just the configuration, but also allows you to see the cusp and the exact hole in between and how to aim. But you can tell the general aortic configuration by the shape of your wire and your catheter. If your catheter and wire in the aorta are falling down, you know this aorta is kind of a horizontal aorta. If they are straight up, you know it's less of a horizontal aorta, more oblique or vertical aorta. So the shape of your catheter in an LAO view tells you how this aorta is. This aorta, for example, is not very horizontal. This aorta is horizontal. This was definitely an Amplatz left case. Maybe here you could have got away with another catheter because it's not as horizontal as of an aorta. It's more like this. I will move on to describe special tips of how to cross bicuspid severe AS. There are special techniques for that. It's often more difficult to cross bicuspid AS than tricuspid AS because the hole in bicuspid aortic stenosis is eccentric. So this is the aortic valve, axial cut, and you see the cusp. 80% of bicuspid aortic valve consists of fusion of the right and left cusp. 20% are fusion of the right and non-coronary cusp. So when you have a fusion of the left and right cusp, LAO is not going to be a helpful view to cross into the ventricle. LAO normally spreads apart the right and left cusp, as I explained in the past. However, when you have that configuration of a fused right and left cusp, the hole is in an anteroposterior plane. It's no longer in a right to left plane. So doing LAO is not going to spread apart your cusp and show you the hole. You need to do RAO view to see the exact hole and aim for it. So RAO is orthogonal to the cusp and separates the posterior cusp from the anterior cusp in bicuspid AS. Now, if you have the other configuration, fusion of the right and non-coronary cusp, then LAO view may help you. Sometimes even RAO view is not going to help. But if that doesn't help you, you may even need to do some angulations, maybe like RAO with a little caudal. If you do LAO view in a bicuspid AS, this is what you will see. Instead of seeing two cusps with a hole in between in a tricuspid AS, in a bicuspid valve, you're not going to see that. You're going to see just one dome. Almost you see one dome flopping around up and down, and you see a shadow of a hole moving, but it's not, you're not looking at it. It's behind you. It's behind that dome that's flopping around. So you need to do another angulation to get you to something like that, to a separation between two cusps. So remember that tip. It saves me a lot. Early in my career, I used to use it still LAO in bicuspid AS. And those were the AS that I had hard time crossing till I changed technique and I started to find different configuration to aim at that hole. Another idea is bioprosthetic aortic stenosis. In those cases, I would do probably aortic root angiography in both LAO and RAO view, and sometimes with a bit and cranial and caudal angulations if the difficulty persists. Because remember, the cusps are no longer in their proper position exactly. You're not going to have right, left, and non-coronary in their standard position. So you may need non-standard views to image that. But I will start with an LAO cusp angiography and an RAO cusp angiography. One of you asked me, how can you differentiate a right cusp from non-coronary cusp? In an LAO view, it doesn't matter. LAO view, which spreads apart right and non-coronary cusp from left cusp. Right and non-coronary cusp will be the lowermost cusps. Right and non-coronary cusp will be here, and left coronary cusp will be here. The lowermost will be right and non-coronary, and the higher will be left. It doesn't matter. On this view, the right and non-coronary cusp are superimposed and are lowermost. Just aim to the hole between those, whether it's right or non-coronary cusp and left cusp. So you don't have to differentiate between the two. I want to quickly show some hemodynamics. So I explained that we do all this most often to measure LVEDP. So I want you to recognize what is LVEDP. So LV end-diastolic pressure is the point on the LV that follows the A wave, the LV A wave. It's often a point on the LV upslope after a bump. So you look on the LV tracing for a bump on the upslope of the LV. That bump will be the A wave. It's not always that obvious. Frequently something like that, small bump like this. And this is the A wave, and your LVEDP is the point that follows it. Now, in cases where you don't see an A wave, for example, if you have atrial fibrillation, in those cases, what you can do, LVEDP will be at the point of the peak of R wave on the EKG. Or if you have a dominant S wave on the EKG, it will be the nadir of S wave. So you take the peak of R and you get the LVEDP, and that's how the computer does it. The problem with that technique, I don't like it too much, because the longer you're tubing, the more delayed is the LVEDP compared to the peak of R wave. But that's a technique you need to know, and it can help you in atrial fibrillation. Another thing I want you to know, LVEDP grossly, we consider it equivalent to the mean wedge pressure. That is often true, but that's not always true. There could be discrepancies between LVEDP and mean wedge pressure. This is such a case. This is a patient who has a high LVEDP of close to 25 millimeter of mercury, yet a low or normal pre-A LV diastolic pressure of about 12 millimeter of mercury. This patient has a mean wedge pressure that is normal, that approximates that pre-A LV pressure, while he has a high LVEDP. Mean wedge pressure, which is mean LA pressure, averages the pressures over the whole cardiac cycle, which are normal in this patient, except when he gets an overshoot of pressure after A wave. So this patient has normal mean LA pressure throughout the cardiac cycle, except after A wave. So he has high LVEDP, which corresponds to the post-A LA pressure and wedge pressure, but a normal mean wedge pressure, which in his case matches the pre-A LV diastolic pressure. And always think of that whenever you have a low pre-A LV diastolic pressure and very high post-A LVEDP. Think of that. And those patients tend to be what we call compensated LV dysfunction. So they are not in pulmonary edema, they are not having dyspnea at rest, but they are prone to go into pulmonary edema. They are compensated LV dysfunction. However, when you're in decompensated LV dysfunction, then everything goes up. The whole LV diastolic pressure goes up and the LVEDP goes up. And now your mean wedge pressure is high, and now your mean wedge pressure matches the LVEDP and may actually exceed the LVEDP if in those decompensated cases you have a big V wave from the LA and wedge pressure. Okay, so generally mean wedge pressure matches LVEDP in normal people and in most cases of LV failure, but in decompensated LV dysfunction, especially decompensated LV diastolic dysfunction, you can get that discrepancy, higher LVEDP than wedge. And in cases of big V wave with decompensated left heart failure, your wedge may be higher actually than LVEDP. This is an illustration of that phenomenon. If you need more info, I have a separate video for that. Another case we see not infrequently these days is that, okay, I cross the ventricle with my catheter and I'm getting pressures, and all of a sudden I see this. Usually the fellow's immediate reflex, or they think, oh, we're damped, our catheter tip is against the wall. That's the wrong answer. Look at that nice tracing. You can, I don't have the EKG here, but you can actually time it to the EKG. You have A and V wave. This is actually not infrequently seen these days. This is actually a catheter that falls into the left atrium instead of the left ventricle. It happens more in radial, partly because, as I explained in the past, the radial catheter likes to hug the outer curvature of the aorta, and it's hugging the outer curvature of the aorta. It tends to point in this direction in the ascending aorta, and it may point in this direction in the ventricle and point toward the left atrium. So in an RAO view, which is the long axis view of the heart, if you see the catheter pointing like this, well, you're going into the LA and you're getting this. What you do, you torque the catheter out, away, and you get into the left ventricle. You can get this with a Judkins right catheter, with a Tiger catheter. It happens from a femoral axis at times, but it is harder. And you can even aim to get the left atrium by torquing the catheter from here to there. I must say, though, all the times I've done this, the V wave of the LA tracing tends to be large. So I wonder whether this retrograde LA recording creates some degree of mitral regurgitation, depending on how the catheter is being tangled with the chordae and tethering them potentially. So I'm not sure this LA tracing is a true reproduction of the true transseptal left atrial pressure. I have yet to prove that. But my impression is that you exaggerate V wave when you're doing this. I want to move on to describe left ventriculography. Okay, so I explained that in order to do left ventriculography, we have to cross the ventricle using a pigtail catheter. And there are several tips to doing left ventriculography. One, the view. Even though I cross into the ventricle using an LAO view, in order to image the heart, I use RAO. So LAO spreads nicely left heart and right heart, left cusp and right plus non-coronary cusps, and allows me to cross. However, RAO is what spreads anterior, posterior very well. And in the case of the heart anatomy, it spreads very nicely. Ventricles on one side, anterior, and atria on the other side, posterior. And it will show you the long axis of the heart. And this is the typical left ventriculogram morphology in an RAO view. The problem when we're doing fluoroscopy, we're doing 2D and we're only seeing the contours, the outer contours, outer shadow of the heart. So in an RAO, you're going to see the anterior wall and you're going to see apex and inferior wall. You're not going to see the septum, which is lower in height than the anterior wall. The septum will be somewhere here. And important, you're not going to see the posterolateral, that posterior lateral wall, which will be engulfed in that area of the heart, okay? Because it's 2D imaging. If you want to see the posterior wall and the septal wall, you need to do an LAO view, okay? But the typical view is RAO, which shows you most of the wall except the posterior lateral wall. So you can have somebody with an acute posterior infarct who has somewhat normal LV gram if there's an isolated posterior lateral infarct because you're missing the posterior wall. Again, in this view also, you're not going to be able to assess, for example, LVOT narrowing. If you're looking to see LVOT narrowing by angiography, you need LAO view. But anyway, in an RAO view, those are the typical wall, anterior, inferior, and apical. There are tips to doing LV gram. One, your catheter has to be free in the mid cavity. It should not be in the LVOT, otherwise you're not going to fill your ventricle, particularly your apex. So you need to be deep into the ventricle, not LVOT. However, you don't want to be at the apex because you inject dye in that apex. The apex is very arrhythmogenic. You're going to get what we call VT gram. Also, you don't want to be, as it frequently happens, you don't want to be tangled in the mitral valve apparatus. the catheter needs to be free. So as you're positioning it mid-cavity, you see the cardiac silhouette, and you want it to be in the center of that cardiac silhouette. And you want to move it a little bit forward and backward, make sure it's free. If it is not free, you're tangled into this, and you'll have bad consequences. One, when you're tangled into this, you'll create a fake MR because you're tangled into that mitral apparatus, you're tethering the cordae, you're creating fake MR. Two, you're injecting into one zone of the heart. So there is a risk of creating a stain and even a perforation depending on the volume you're injecting. And three, you're going to create PVCs and VT, which will make your LV-gram less useful also as well. So you need to be free in the mid-cavity. Now, how much to inject? In standard cases, if you're just doing it to assess LV function, I usually use 8 milliliter per second for a total of 20 to 25 milliliters. So relatively on the lower end volume. I've done it with even less, 7 milliliter per second for 15 milliliters. So you can be conservative. If your LV is large and dysfunctional, you probably need more than that. And as I will explain in MR, you need around 50 milliliters. Make sure when you're injecting the big volumes in particular, your LVEDP has to be low. So ideally, your LVEDP has to be less than 20 when you're doing this, definitely less than 25. If it is high and you really need to do LV-gram, give nitroglycerin to the patient before you do LV-gram. Otherwise, he'll go into flash pulmonary edema. So LV-gram, do it when LVEDP less than 20, definitely less than 25 millimeter of mercury. So I said, this is REO. Now, if you want to do LAO, it will show you the septum and the posterior wall. But again, we're doing 2D, and LAO will superimpose, will be foreshortening those septal and posterior wall. So even LAO is not going to show very well the septal and posterior wall. So this is LAO. It will show you septal and lateral wall squished together. So to get a good LAO view, you have to go cranial, look from above. And now you separate nicely the lateral and septal wall. You can actually see the LVOT. You can see narrowing of the LVOT if you want to see that. In HOCM, you don't really need to see that. You can even spread the LA and see mitral regurgitation. In this view, the LA is foreshortened. So you're not going to see the LA if you do LAO this way, the LAO straight. You need LAO cranial. But we often don't need the LAO. If you want to remember one view, it's just the REO. And if you do LAO, do it with a little cranial to attenuate that foreshortening and have a nice long axis view of the ventricle. So how to assess mitral regurgitation using left ventriculography? It can be very, very useful, left ventriculography, in cases of mitral regurgitation of questionable severity, especially eccentric mitral regurgitation that is underestimated by echo. It can be very useful because it's a qualitative but volumetric assessment of mitral regurgitation, unlike echo, which is Doppler velocity assessment of mitral regurgitation. So the way we do it, one, you have to put definitely 6 French, no less than 6 French, pigtail catheter in the mid cavity, as I explained, not tangled into that mitral apparatus. 2, you have to give big volume. So you have to give 50 milliliters, and you have to inject something like that, 13 milliliters per second, but for 4 seconds. The idea here, we're trying to fill the LV and the huge LA that is often bigger than the LV in systole. So we're trying to fill 2 big compartments. So we need, for that reason, you need large volume. And you need large volume sustained over several seconds to achieve a steady state contrast opacification of both those large LV and LA. In fact, we compare the opacification of the ventricle to the opacification of the left atrium in order to assess the severity of mitral regurgitation. Third tip, again, mid-cavity, not tangled in the mitral apparatus. If you're tangled in the mitral apparatus, you'll create fake MR, as I explained. Also, you want to not have a lot PVCs and VT. The problem, if when you're injecting, you create a VT, you will also exaggerate MR. When you're having VT during LV-gram, VT will make the ventricle, left ventricle kind of in a standstill position that will keep the mitral valve open, and that will create or exaggerate the severity of MR. Another tip is, while I do the LV gram usually in a 30-degree REO view, the problem with the 30-degree REO view is the descending aorta will be superimposed with where the left atrium is. And remember, to assess MR severity, I compare LV opacification density with LA density. Well, if I have a descending aorta, this is a catheter. This is where the descending aorta is in a femoral access case. So if that descending aorta is overlapped with my LA, it will exaggerate the density of LA, and I won't be able to really qualitatively compare LV and LA. So you really, in order to avoid that descending aorta from being overlapped with LA, you have to go steep on the REO. Instead of 30-degree, my standard REO angle, I go steep, 50 degrees, even 60 degrees. So keep that idea in mind, steep REO. You can also do LAO cranial. That's another technique that will show you well the LV, LA without aortic superimposition. Now, how do we grade mitral regurgitation? So there are 4 grades by LV gram, and you need to know those grades. We use them, 1+ to 4+. 1+ means you see the width of contrast going from the LV backward, but you don't see the full LA contour. So it's mild MR. 2+, you see the full LA contour, but that LA filling is milder than the LV filling. Again, it's qualitative. It's an eyeball assessment. 3+ means you're seeing the full LA, and the LA density is as much as the LV density after several beats. 4+ means you're seeing the full LA, and the LA density is worse than the LV density at the steady state, or it's as bad as the LV within 1 beat. Okay, and remember, we're doing that comparison at steady state when both the LV and LA are filled, and it's a steady state filling. It's not changing much anymore. This is when we compare the LV and LA. We don't compare them at the very beginning when inherently the LV is more dense, or at the very end when inherently the LA may be more dense. And that's the reason why we give a large injection sustained over time to achieve a large volume steady state filling. So 3+ and 4+ are what we call severe MR. So 3+ is already severe and qualifies for surgery if you have the other indications for replacement of the valve or repair of the valve. So again, 3+ LA at steady state as dense as the LV, 4+ LA denser than the LV, or as dense as the LV within the first beat, where you haven't even achieved the steady state. You're already within 1 beat as dense as the LV. That's 4+, but you don't need that to call it severe. 3+ is already enough. Another indication of 4+, a little difficult, is you see the pulmonary vein. You see contrast, and you see contrast filling in the pulmonary vein. The easiest to see is that left upper pulmonary vein, sometimes the right pulmonary vein, and that will indicate 4+ as well. So similarly to MR, I will describe how to assess AI. It's kind of similar concept. So this is a patient who has bicuspid aortic valve and eccentric AI that is moderate, or called moderate on echo, but he has some indirect sign of severity. His LV is dilated, he's having symptoms, and he has hollow diastolic murmur on exam. So we did aortogram in this patient. And here you can see same sort of assessment in aortogram. So when we want to do assessment of AI, instead of doing LV gram, we do aortogram, and we compare filling of the ascending aorta versus filling of the left ventricle, and use the same subjective, qualitative, volumetric assessment, aorta versus LV. And here you can see the LV is eventually at steady state. The aorta and the LV are almost the same density. So I ended up calling this 3+ AI. Again, at steady state, look at that LV here. After the first 2 beats, look at that LV and look at that aorta. They are equal. Don't look at where the catheter is exactly. Look at the overall aorta and the overall left ventricle, and you can see they are almost equal. So this was 3+ AI. Importantly, the LV fills in 1 beat. That's also a hint. Within 1 beat, you're already full in that LV and quite dense. That's concerning for severe aortic insufficiency, 3 or even 4 plus, if it is already as dense in one bead. Okay, so this is how we proved severe AI by angiography. The idea is that here echo frequently underestimates AI and MR severity in eccentric jet, because in those cases the color abuts a wall and quickly abates. Echo color correlates with velocity more than volume. The AI or MR volume may be high, yet the color may abate quickly if it is eccentric and it hits a wall. So this is where LV-gram or MRI these days are better modality in those cases. And, you know, the best is MRI these days, not LV-gram, but MRI is not widely available. So LV-gram is very handy in those cases. And the way I do the aortogram is kind of similar tips to MR. I'm injecting dye in the aorta. I need large volume steady state filling. So I do, and it's even larger amount than we do in MR. It's a total of 50, 60 milliliters for 20 milliliters per second. So larger volume to fill that, usually dilated aorta and dilated, very dilated ventricle. Remember, you get the largest ventricles in AI and you do get dilated aorta frequently. So you need that large volume, 60 milliliter, 20 milliliters per second. And you need LAO, not RAO. We use typically LAO for imaging because LAO will spread that aorta, ascending aortic arch, descending aorta, and will prevent that superimposition of descending and ascending aorta. Unlike RAO, which superimpose them, also LAO will show you the size. You can measure the size of the aorta in those patients with severe AI because you need to assess their ascending aorta as well. Remember, when you want to give those big volumes, you really have to make sure that LVEDP is not high. And in the case of MR, you have to make sure the patient is not in decompensated failure. You give that big volume in a patient with AI or MR, you can create a flash pulmonary edema. This is another angiographic feature of aortic insufficiency. Beside aortogram, this is what you can see. I want you to recognize this. We get a reverse diastolic flow into the coronary. It's like a bridging, it's milking of that coronaries, but it's happening in diastole as the flow is going retrogradely with the AI in diastole. You can see it here as well. It's more subtle, but you can see it here in the PLB branch. In diastole, as the heart is relaxing, you can see it's becoming faint. As the heart is relaxing, you can see it's becoming faint. So that's another sign of severe AI, pathognomonic for severe AI. I'll show you one last case here. This is a 71-year-old with a history of mitral valve prolapse, and he's having worsening dyspnea. Echo is read as moderate eccentric MR. He has severe LA enlargement, and his EF is 55%, which if he has severe MR is already declining. So he was referred to us for coronary angiography by the referring doctor. But when we reviewed his case in the morning, we decided we need to do left ventriculography because that MR may be more severe than assessed. And, you know, it's a very eccentric MR from a posterior mitral leaflet prolapse and a very eccentric MR that could be underestimated. And you can see here almost a quanta effect of that very eccentric MR. So we decided to do LV-gram in this patient. Again, we did it in a very steep RAO to open the left atrium, and we injected. Now here, you can see we filled retrogradely that LA, okay? It was hard for us to achieve a steady state. At steady state, after a 3 beat in this case, usually steady state is after 2-3 beats. After 3 beats in this case, if you compare that part of the ventricle to the LA, they are about equal. So we called it 3+. I want to give here a caveat of that classification. I said that 3+, in 3+, the LV and LA are equal density. But keep in mind, frequently, when you have severe MR, your LA may be bigger than the LV. And actually, in this patient, by echo, LA was much larger than the LV in systole. So imagine if you have 50% regurgitative fraction, which is what defines MR severity by echo and MRI. You have 50%. That volume you're injecting is being split in half between LA and LV. Well, if the LA is much larger than the LV, even if 50% retrograde filling will end up causing the LA to be less dense than the LV. You need to have a 75% regurgitative fraction to have them as dense. So that's why I take into account the LA size. If I have a huge aneurysmal LA, then even what looks like 2+, like an LA less dense than the LV, is probably 3+, because the LA is much larger, and therefore even a 50% regurgitant filling will cause it to be less dense than the LV. So we call it 3+. Eventually, this patient had TEE that unquestionably confirmed the severity of this MR. He has the Coanda effect, color wrapping all around the LA. He also had a big PISA, interestingly. You know, PISA underestimates MR severity in eccentric MR, but despite that, a proper PISA was very large, over a centimeter in this case, with a proper Nyquist limit, and he eventually was sent to surgery. You know, his EF dropped after surgery because, remember, even 55% is already too low in a patient with severe MR. 65%, over 65% is where you should be. His EF dropped to 20% post-op. Eventually, several months later, it went up to 40%, but it never went up to normal. There is one comment by Dr. Rawson. The catheter position in this case is not ideal. You want to be a little above the valve. You ideally need to position the catheter somewhere here. And as you're injecting that big volume, the problem, the catheter may flip out of the aorta. So you need to keep forward tension on it as you're injecting. You need to keep your hand on it to keep forward tension.